Welcome, everyone. Good morning. So glad to have you here to this CAPS lecture series featuring and focusing on the topic of context of care in the aging Latino population, Mexico, and the United States. Rebecca Wong and I organized a panel at the invitation of Deb Umberson, who is the director of CAPS, along with Karen Fingerman, who's the co-director, to highlight the work of our ICA and Texas RICMAR investigators, focusing on Latino health and aging, with a special focus on the Mexican origin and Mexican American population. I want to thank Stacy Brody and the PRC staff for their help with this logistics. And Rebecca Wong, you want to wave your hand up there just so everybody knows we've enjoyed putting this all together. Let me turn to how we're going to organize ourselves this morning rather. I want to first of all introduce individually the invited speakers, and I'll do that one at a time. And I just also want to point out that Rebecca Wong will be serving as a discussant for this session. And you will have an opportunity to ask questions. And to do this, please use the chat box to post them. Something that maybe needs to be clarified. Rebecca is going to monitor the chat. We're also going to take some time after each presentation for Q&A, and we'll do this one at a time. Let me introduce our first speaker, coming in from California, bright and early, Dr. Jacqueline Torres. Jackie, great to have you here. Dr. Torres is a social epidemiologist and assistant professor in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. Jackie's current research focuses on the role of policies, families, and community social networks in shaping population health and health inequities, particularly in mid and late life. Her ongoing research is examining the role of family social connections, caregiving, and household composition changes in shaping late life health, including Alzheimer's disease and related dementias. She approaches her research from a life course perspective and a social determinants of health framework. Much of her ongoing research, which is funded by the National Institute on Aging and her pilot by the Texas RICMAR, employs modern epidemiologic methods that are better equipped than conventional methods at estimating the impact of time-varying exposures in the presence of time-varying compounding. Dr. Torres is also supporting trainees at all levels who are leading research broadly on the social determinants of inequity in health and aging, and specifically related to policy impacts on the health of immigrants and their family and community members across the life course. With that said, thank you so much, Jackie, for being with us this morning. And we'll turn to you now for the title of your presentation.
Yeah, thank you so much, Jackie. Thank you for the invitation to you and Rebecca and to the CAPS family for the invitation. And I'm going to share my screen, and while I'm doing so, I'll just say that I'm not going to live up to that description because I'm actually going to present something that's pretty descriptive. And let's see.
Let me, while you're waiting, Jackie, to get that up, I'm going to just share with everybody the title of your presentation: Living Alone in Late Life Prevalence and Outcomes in the US and Mexico.
Yeah, thank you. Thank you. So yeah, as I said, I'm going to present something that's relatively descriptive compared to what I usually present, which is usually on trying to understand the causes of late life health outcomes. And as I'll kind of allude to, but won't have time to discuss, I think studying living alone in late life, which is the topic of my presentation, is really hard to study as a cause, and actually may not be fruitful or kind of useful to study as a cause, but is definitely worthy of focusing on in as we think about late life and caregiving. So this work stems from a project that I just began as part of a R01 and initiated actually as part of an R56 with some collaborators who are both ethnographers and social epidemiologists at UCSF. So I want to acknowledge them and their work. So my colleague, Dr. Elena Portocolone, is an ethnographer at UCSF who focuses on the lived experience of living alone among older adults, including among older adults with cognitive impairment who remain living alone in the community. In one of her earlier qualitative studies several years ago, she asked one of her participants, a 92-year-old man who had lived alone for his entire life, about his experience. And she asked, is feeling alone, given your experience of living alone, the same as feeling lonely? And he responded, no, I feel not necessarily lonely, but I do feel alone. And so he's kind of highlighting, really the fact that living alone is not necessarily the same as loneliness, that not all people who live alone in late life feel loneliness, although it's definitely correlated in some cases. But there is this unique experience and unique attention that we need to pay to the experience of living alone and potentially feeling alone, as this participant says. So in the US, 27 to 30% of adults 60 years and older live alone. It depends a little bit on sometimes the age cutoff and the year, and there's some suggestion that the prevalence of living alone maybe peaked maybe prior to or around the Great Recession and is declining a bit. There's also a substantial population level heterogeneity. So for example, in the current population survey, pooled across many years, the prevalence of living alone in the US was 36% for Black adults 65 and older, 30% for white adults at the same age, and 20% for Latinx adults. And there's also substantial variability by gender. So for example, another recent study using National Health Interview Survey data, again pooled across many years, found that among those living alone, 69% were women and minority were men. There's also substantial variability by immigrant status, by country of origin, and age at migration. And this really compelling example by demographers Gubernskaya and Tang, they reported that among adults who are unpartnered using census data between 2008 and 2012, the prevalence of living alone among Mexicans living in Mexico was somewhere close to 30%, but not quite. While for US born Mexican Americans, it reached up to 45% or thereabouts, was much higher for US born non-Latino whites. And then there was a lot of variability among Mexican immigrants based on their age at migration, with those who migrated at 50 years and older being much less likely to live alone if they were unpartnered. So you can see this, a lot of population level heterogeneity. So also reflecting kind of this, cross-national difference in the prevalence of living alone. This is a plot of census data from many countries around the world and kind of plotting the prevalence for women and men 65 and older living alone. And so here you can see Mexico the same as many other countries where the prevalence of living alone among women is higher than among men, which is plotted, the prevalence for men is plotted along the x-axis, but it's still, the overall prevalence is much lower than the US. But this still means that based on the most recent data that I could find, based on the 2018 Andrade, a national demographic survey, that 1.7 million adults 60 years and older in Mexico live alone. So the prevalence of living alone is lower than it is, lower than the prevalence of living with others, and it appears to be relatively low, for certain population subgroups, men, for Latinx older adults in Mexico, and so forth. So why focus on older adults who live alone as we think about caregiving and as we think about late life if it's relatively low prevalence compared to other living arrangements? So one reason is that the prevalence of living alone is highest among the oldest old. So in the US, up to 32% of women and 18% of men 65 and older lived alone in 2014, based on American Community Survey data. But this rose to an estimated 46% of women and 27% of men 85 and older who lived alone in the same year using the same data source. So you can see that there's this huge jump in the prevalence of living alone among the oldest old, for whom we might be thinking more intensely about caregiving. Older adults living alone versus those living with others have also been observed to have more financial strain, poor mental health and physical health. And also, this may feel like, particularly salient for this year, no matter where you live, but older adults who live alone have been observed to be more negatively impacted by climatic events such as heat waves and natural disasters because of the limited kind of availability of co-residents to support in taking the kind of urgent action that's needed in the case of acute and chronic climatic events. But findings can be mixed. You can, I've done analyses myself and find many other studies showing that those living alone can have better health than their counterparts living with others. And it's really hard to isolate living alone as a cause of health and potentially not very fruitful. So which is why I've really focused in this talk on description, and in my work on living alone have been focusing on what we can do to kind of optimize the experience of living alone, if that is the preference of older adults who remain in the community, and optimizing outcomes for those living alone, rather than kind of running models in which we're pretending that we might be manipulating or changing the living arrangements, which seems less feasible. So another reason to focus on those living alone is that the prevalence of living alone with cognitive impairment, continuing to live alone after the onset of cognitive impairment, remains relatively stable, or potentially even higher, given that there's that kind of increased prevalence of living alone with older age, and cognitive impairment and dementia are age-related diseases. So in the US, an estimated 1/3 of adults 65 and older with probable dementia or cognitive impairment live alone. A recent study done by our colleague, Dr. Silvia Mejia Rango, just put out this last year, found that in Mexico, an estimated 22% of men and 26% of women 82 years and older with probable dementia, based on their survey responses, lived alone. And this was similarly high among Mexican American men and women with dementia. Compared to those living with others, those living alone with dementia have been identified to have higher risk of adverse events in their home, such as falls or accidental fires, and a higher prevalence of unmet need with activities of daily living, managing money, medication, and so forth. But there's really been little population level research focusing in on this group of older adults living alone with probable dementia. So my colleagues and I recently undertook this study where we really wanted to characterize the population of older adults living alone in the US. using data from the US Health and Retirement Study, the population of older adults living alone with and without probable dementia and cognitive impairment. So we compiled data from a number of years from 2000 to 2014 in the HRS, and we allowed people to enter from each cohort once they experienced the onset of probable dementia and as they came to live alone. And so we estimated that in any given year over the study period, approximately 1 million community dwelling adults 50 years and older were living alone with probable dementia, and another 3.3 million adults were living with probable cognitive impairment at any given point. And we wanted to do some comparisons to see what were the characteristics of living alone with and without probable dementia. So those living alone without cognitive assessments that suggested dementia versus those living with, and had survey assessments that suggested that they might have some cognitive impairment or dementia. So we found that those living alone with probable dementia were, as you might guess, older than their counterparts without. And we found that, although the overall prevalence of living alone is estimated to be much lower among Latinx older adults in the US, that they were more represented in the group living alone with probable dementia and cognitive impairment. And that was also true for Black adults in the HRS. And so this suggests that even if, the prevalence is relatively low of living alone overall, that there may be there's a greater representation of living alone with probable dementia and cognitive impairment, suggesting a greater need for assistance with activities of daily living. And so we actually also looked at just this. So we wanted to look at kind of among those living alone with probable dementia and cognitive impairment without dementia, again, just focusing on that specific group. What was the prevalence and what were the population level differences in the prevalence of having a need for care with activities of daily living, those basic activities of daily living, as well as the instrumental activities of daily living, like managing money and shopping and so forth, or preparing hot meals. So we found that particularly for women, there was these racial and ethnic disparities in the prevalence of any difficulty, any need for assistance with activities of daily living, even among this group of people who are living alone with probable dementia and cognitive impairment, with the prevalence of any ADL or IDL difficulty, the highest for Latino women. And then we also wanted to look at who is receiving help. So what was the prevalence of receiving help once you said that you had a need for assistance with activities of daily living? So we found that Black women were 22% more likely to report having a difficulty but not receiving help, whereas Latino women were 36% more likely than their white counterparts to report that they had a difficulty, but they actually did receive help. Now, those of you who are familiar with these questions in the US Health and Retirement Study know that these questions about getting help are actually meant to capture the severity of difficulty and not necessarily an unmet need. And so we really can't actually tease apart whether, for example, that high prevalence of difficulty with help is reported because there's actually more help received, so fewer unmet needs, or the severity of ADL difficulty is actually higher, because the latter is what the HRS was meant to capture, but we know that there's probably some kind of picking up of unmet needs, and which is what we actually wanted to capture. So a little bit of measurement frustration. And then we actually saw limited disparities for men and overall lower prevalence of ADL and IDL needs, although the prevalence was still remained high. I'm going to skip over this, which is digging into the specific ADL and IDL difficulties in the interest of time, because I want to also just put out there, and bring up the context of COVID and living alone in the context of COVID-19, the pandemic. So these are back to the qualitative research that my colleague, Dr. Portocolone, and her team have done following the same people living alone with cognitive impairment through the COVID-19 pandemic. And many of these, this is all based in San Francisco. Many of these, this is a very diverse group. And so 3 of the respondents who are represented with these quotes are Latinx, older adults. And one of them said, there's a big difference right now with being in isolation compared to before. And another said, I sit at home all day and I think too much. I didn't think so many things when I was at the senior centers. Another says, I would go to the senior center to waste 4 or 5 hours playing and all of that, and I would entertain myself there. So talking about the things that are lost, that living alone does not, again, necessarily mean isolation, and the context of this kind of system of social support and long-term services and support. There may be actually kind of robust networks built, but that many of them were lost in the context of COVID. And the last respondent says, if I go out and walk down the corridor, another woman comes out and we talk for a little while. But it is difficult now, all the doors are closed and you don't see anyone. So this is probably not really surprising, but just want to kind of drive home the importance of focusing on this group of people living alone in the context of COVID, including with cognitive impairment. And this is, I just wanted to end with some preliminary data that we're looking at with the 2020 Health and Retirement Study. They've released data on a small subset of their overall respondents. And we found that, again, nearly 25% of respondents overall to the HRS continued to live alone in the context of COVID. There was much less switching in and out of living arrangements. This was fielded starting in June 2020, and much less switching than we expected. We thought there was going to be a lot of kind of churn, but we did not see, a lot of switching. It was a question that was asked. And again, we see differences by race, ethnicity. And I want to just show our preliminary results for looking at kind of COVID-related hardships and also receipt of support by living arrangement. So I didn't even plot the prevalence of COVID-19 positivity because it's actually wouldn't appear visible on this chart. 2 respondents who lived alone reported having ever received a positive COVID test during the time period that this was fielded, compared to 35 or so of those living alone. So it was actually a really big gap for this small sample. So those living alone were protected relatively to those living with others from COVID infection, but they were more likely to report delayed medical care, that they couldn't afford food, they couldn't afford to pay medical bills, and that they missed other critical payments. They were also more likely to report receiving help with money, with financial needs, and also much more likely to report receiving help with chores and things around their home, although still the majority reported receiving no assistance. And we're looking at these outcomes by race, ethnicity, and so far seeing that, when you look amongst data and gender, by gender and race, ethnicity, that you see, this is for financial hardships, that, where you see disparities by living alone versus living with others, those appear to be relatively consistent by gender and race, ethnicity.
We're at 18 minutes.
Okay, well, I'm going to wrap up. So just want to conclude by reviewing again that in the US, an estimated 20% up to 30% of older adults live alone. But among those living alone, between 27% or 30 and 31% of men meet criteria for probable dementia or cognitive impairment without dementia. Put differently, an about 30% of people with cognitive impairment or dementia continue to live alone. The prevalence of living alone is lower among Latinos in the US and in Mexico. But we saw similarly high prevalences of living alone with probable dementia and cognitive impairment in Mexico and among Mexican American older adults in the US. And in the HRS, we saw that a higher prevalence of US Latinos who were living alone with dementia or cognitive impairment than without had higher prevalence were living alone with dementia or cognitive impairment than without dementia or cognitive impairment. Latino women reported a higher prevalence of IEDL difficulty and also difficulty with help received, which, as I said, is potentially indicative of a higher severity of difficulty, but also wrapped up in that is, obviously something about the help that they're receiving, but the HRS doesn't allow us to disentangle that. And thus far, we're seeing that living alone, while it may be protective for COVID infection, may be a risk factor for some adverse outcomes of the COVID-19 pandemic across racial and ethnic and gender subgroups. And I'm going to end there, and I'm happy to take any questions.
Very nice. And maybe we could put an electronic clap, something like that.
Yeah.
Thank you so much, Jackie. And Rebecca has been monitoring the chat with questions. I have one.
Thank you. Thank you, Jackie. Very interesting talk. We appreciate you staying with the time limit. And yes, there's a question here from Jackie Angel. I'm going to read it. What are your thoughts on why women are more likely than men to live alone in Mexico, especially those individuals with dementia? Any insights that you could share with us?
Yeah, so the biggest predictor of living alone in the US is widowhood. When you look at a population level. And that's the most recent data that I could find put out by INEGI in 2019, based on 2018 survey data, kind of looked at the data a little bit differently, but did report that a high prevalence of women living alone overall are widowed, report being widowed. And so given the longer life expectancy of women relative to men, that's I think one of the biggest drivers. And that's actually why it's really hard to tease apart living alone as a cause, because it's very hard. Widowhood is such a strong driver of living alone on a population level that it's really hard to find, a comparable group of people living with others who've been widowed that are a sizable number. They have to be living, that are living with others, say kids or, other family members, that are also comparable across health measures and all of the other characteristics that we would, and age, characteristics that we'd like to balance out in order to understand really, living alone as a driver of these health outcomes.
Thank you, Jackie. I'm going to read one more question from Deborah Umberson. I'm wondering about other measures of social isolation and if they parallel patterns for living alone. For example, are there similar patterns for frequency of contact with friends or family or religious participation?
Yeah, that's a good question. So religious participation, I'm not sure. And yeah, there are plenty of other social isolation measures, and living alone absolutely is correlated with social isolation. But definitely not deterministic of it, as reflected in the quotes. I think that that's something that we'll be looking at with the COVID-19 data to the extent that we can measure it. But I've not seen evidence that, for example, those living alone are less likely to engage with friends and family and other people in their social network. That's a good question. I don't know if you're kind of thinking about like some innate or some kind of maybe personality or other kind of aspects of isolation.
I guess I was wondering about compensation, so that if you live alone, maybe you see friends and family more, and maybe that happens more for older Latinx populations than for other groups. That's kind of where my thinking was.
Yeah, that's a good question. I'm not sure. That seems like an important hypothesis to test. I know that there's been a lot of data finding, or a lot of studies that have found that living alone may be more detrimental for the health of men than women. And one of the driving hypotheses for that is that women may compensate with other social networks and connections with family members and children and so forth, whereas that may be less true for men. And so the impact of living alone has been found to be, stronger for mortality and all sorts of other health outcomes for men as opposed to women.
Okay, thank you very much. We're going to encourage people to write more questions if they have them on the chat, and we're going to go on to the next speaker.
Thank you, Rebecca. Our next speaker comes from the University of Illinois at Urbana-Champaign. Welcome, Flavia Andrade, who's an associate professor at the School of Social Work. Dr. Andrade also holds appointments in the Department of Sociology and Kinesiology and Community Health. She's a fellow of the Gerontological Society of America and also serves on our conference series on Aging in the Americas Advisory Group. Dr. Andrade is exploring how transitions at the population level, such as demographic, socioeconomic, nutritional, and epidemiological, are influencing health across the life course. And currently her work is focusing on the health of adults and older adults in Latin America and the Caribbean and Latinos in the United States. Her current research is focusing on several specific outcomes related to chronic conditions, diabetes, management and hypertension, quality of life, disability, cognition, mental health, oral health, and life expectancy. She's involved in several international projects aimed at understanding determinants of health disparities. The ultimate goal of her research agenda is to identify factors that are more malleable to changes through interventions and policies. The title of her talk today is Unmet Needs for Personal Assistance Among Older Adults in Mexico. This is a longitudinal analysis, 2001 to 2015. Please, everyone, welcome Flavia Andrade.
Thank you, everyone. Thank you, Jackie and Rebecca for the invitation, but also for the organizers of the CAPS as well. Let me share my screen here. All right, can you guys see it? Good, all right. So I want to acknowledge first also my co-author, Mariana Lopez Ortega, that contribute worked with me in this project. So give some background. I think that for this audience, I don't need to say much, right? But we know that the population in Mexico is aging fast. There has been important gains in life expectancy. And if we look at life expectancy at age 50, right, it's like already like at 32 years for women and 30 years, like 29 years for men. But a good chunk of these years are expected to be lived with some sort of, let's see, there's something, like I won't look at the chat anymore, with some sort of like disability. So it's great for me to follow up the conversation that Jackie had, because as we think about support and like disability at this older age, this living environment and the living arrangements actually play an important role. Right, those what we would expect because of the increase in the proportion of older adults and higher number of people reaching these older ages as to have an increase given the trends in disability So we would expect more people to have disability, but also there's a higher risk of having unmet needs. This is some data from SAGE, and the blue line is the disability-free life expectancy. So the years that we will expect to live at each age without disability, and as age increased, like the axis here was cut, but this is age. This number of years in good health will decrease, and then both the more severe disability that is in green and the lower severe disability, they still like they increase in terms of proportions as we get older. And you know what happens is that because women live longer, women tend to pay a higher cost of having these years with disability. So as we think about the nations, we think, okay, we have a high proportion of people getting older, right? Part of these years at older age will be lived with some disability. So how are we going to provide care for this population, right? But also how we provide care for those who are providing care to these older adults with disability. If we look at Mexico, and this is part of the agenda of the Conference on Aging in Americas, we lack a formal service that can provide these types of help. So there's a growing demand, and the service can't catch up in terms of like what they're offering at the national level, especially in rural areas. So the model that we have in Mexico, but it's also true for most of Latin America, is that a lot of the care is given to the family members, and most of this care it's actually provided by a woman, usually a spouse or a daughter. So when we look at the female caregivers, almost 80% of them actually are in ages that they are in the labor force. They are like 20 to 54 years of age. So they have these demands of having being in the labor force, having their own kids, and providing care for the older adults in the households. When we look at the complete scenario, as we go and advance in this demographic transition, we know that we're going towards like smaller families with fewer kids, especially daughters, to take care of older adults. We have changes in the household arrangements. Jackie was just talking about this number of like older adults living alone, right? Historically in Latin America, living like with multiple generations actually was a way to provide care and exchange of care within the family. But like more and more individuals are living alone or like in the smaller households. Kids have migrated in the case of Mexico internationally. And then we have these women that provide most of the care also being at growing numbers in the labor force. So how we balance, right, this increased demand for care and the supply of care, but also the quality of this care, right? So what we're going to be talking here in terms of unmet needs, it's how we provide and assist older adults with very basic activities. So we are going to be looking at ADL. We are only looking at the self-reported questions, whether or not they received care. So like Jackie already alluded to some of the limitations of these questions. And we are not exploring like the intensity of this care or even like the quality of this care. So it's like our measure is also very limited to that. But I want you to think about what happens when we have these unmet needs, right? So imagine an older adult that has difficulty eating alone, independently, and then if they can't have help, they go hungry. And there are reports of older adults going hungry. Or if they can get out of their bed, like we have falls, right? If they have difficulties moving around, for example, to reach the restroom, like falls are very common at older age. If they are unable to take a bath or shower by themselves, right? There's a lot of discomfort of being not clean. It might go for days, and this may affect your well-being. And if you cannot use the bathroom independently, older adults can get wet or be even soiled in their bed. So it's a lot of discomfort if we think of like these unmet needs. And unmet needs are associated with a whole host of other things. Besides the physical discomfort, like they are associated with psychological distress, with self-rated health, but it goes all the way to death. So we have three aims in this work. First is to look at the trends of like older adults that report receiving personal care when they have ADL limitations. Look whether these care varies according to socioeconomic status, and then estimate the number of years that older adults expect to live with unmet needs in Mexico. So to do that, we use the data from NHAS that a lot of you are familiar with, which is prospective annual study of older Mexicans. The baseline started in 2001. We also look at data of 2003, 2012, and 2015. We use the harmonized data from the Gateway to Aging for 2001, 2003, and 2012, and we use the protocols in the raw data from 2015 to generate the similar estimates, and restricted our sample to those 15 and older. We are going to concentrate in 4 activities of the daily living: eating, bathing, transferring, like walking, transferring and walking or moving around the household. The questions are, because of a health problem, do you have difficulty eating, bathing, transferring, and walking? And the limitation should last longer than 3 months. Those who answered yes can do it and doesn't do it were considered to have an ADL. And if they ask, when they ask, does someone help you? If they say no, that's our measure here of unmet needs. The variables that we're going to be looking at, the regressions will be sociodemographic, will be age, sex, marital status, number of children. Socioeconomic variables will be education, wealth, income, whether or not they receive a pension, whether or not they have health insurance. And for health conditions, we have morbidity conditions, traditional diabetes, cancer, high blood pressure, lung disease, heart disease, stroke, and arthritis. And we also look at elevated depressive symptoms. So because we have 3 different aims, we are using different methods to approach. I'm going to talk a little bit about descriptive statistics. In the Sullivan method to calculate our life expectancy, we also use data from WHO for the life tables, and we use some mixed regression models. Just to give you some idea of like disability in Mexico, and these are the numbers for 2015, those who have disability are older. We have a high proportion of women. They're less likely to be married. They have lower education compared to those who without ADL limitations. They're more likely to be poor. They have lower income. They're more likely to receive pension, but they have similar levels of insurance, and they report more health problems, and they have also more depressive symptoms. So as we focus on this group with more ADL, remember that they are older, more likely to be women from low socioeconomic status, and they also have more health problems. So let me move this here, probably here. So when we look at trends in the prevalence of ADLs in Mexico, it's increasing. And like this first bar here is from 2001, and we go from 8.4 to about 13% of older adults reporting at least having one ADL in 2015 for the ADLs we are considering. The most common ones among the ones that we are looking at is transferring, getting in and out of bed, and walking, with like eating having a lower proportion reporting limitations on eating. When we look at the unmet needs of those with disability, those who are receiving assistance are older. They are more likely to be married, which, so we see the importance of like having someone else to provide care at least immediately in the household. But those receiving care had lower education, a little bit of lower pension coverage. And then they had similar number of health problems, a little bit higher, but they definitely had worse mental health when we look at the descriptive statistics. When we look at those with receiving assistance over time, what we see is that there's a reduction on the proportion of people receiving assistance. And most of this reduction is associated with these mobility issues. So if like for walking inside the household, I was around 60% in the early 2000s. And nowadays, like in the mid 2012 and 2015, it goes to like a little bit over a third of the individuals reporting receiving assistance. Assistance is much more prevalent for like very basic activities such as like bathing and showering and eating. So these still have most of the people reporting that their needs are being met, right? And remember that these are self-reported, so individuals might understand that being met in different ways. And then transferring, getting in and out of bed, the assistance, the reporting of assistance is also decreasing over time. These assistance varies across age groups, and like as individuals get older, for the individuals, for example, 70 and older, we see declines at every age group, but assistance is still much higher at older ages. And this is true for all the conditions. So what we can take it from there, right? So the big trend is that disability is increasing, right? The number of individuals reporting have an ADL, it's increasing. But the assistance, especially for mobility issues like transferring and walking inside the household, is decreasing. And even though there is a decrease also for like very basic activities such as eating and showering, like most individuals still have assistance for like these very basic activities. When we look at the life expectancy expected to be lived with ADL, that's the total of the bar. The green part is the one that's with assistance. Like they say, yes, I'm receiving help for my ADL. And for females, we actually see an increase. So there are more years that they are receiving help, right? But the growth in the number of years without assistance is faster, right? When we look between 2001 and 2015. And for men, actually, the number of years with assistance decreased between 2001 and 2015. So that's like, it's an important trend. When we look at the healthy life expectancy, that is the dark green, it decreases over time. The portion that is like the help with ADL, it's important like in both years, but we see that the portion of unmet needs, that is the red one, really increases by 2015. And for women, this is even more marked. So how is this for these different activities, right? So for walking, we really see this decrease for both men and women over time of the average number of years with assistance for walking inside the household. And the part of the red bar that's the unmet need, it's really growing between 2000 and 2015. The same is true for getting in and out of bed, that the number of years expected to be lived without assistance, it's really growing. But when we look at bathing, that is a very basic need, we have an increase in the number of years with help. And even though we have an increase in the numbers of like unmet needs, it's not as marked as for the other activities.
We're at 15 minutes.
Thank you. And then the same we see here for eating. The unmet needs were almost null in 2001, and they have increased a bit for 2015, but it's not as close to what we saw for the other activities. When we look at the multivariate analysis regression, putting all this data together, we see that what are the factors associated with the ADL help. So individuals that are older are more likely to receive help. Those who are married are more likely to be receiving help. those with more health conditions are more likely to be receiving help, and those with more depressive symptoms. So what will make sense of these, like these results? And I'll skip those here. It seems to us, and like talking with Mariana and other scholars in Mexico, is that as families get trained to provide care, sometimes not only to one older adult in their families, but maybe like two older adults in this family, and sometimes the qualitative studies that support that, they have to optimize how much care they can provide for these activities of the daily living limitations. So they focus on the activities that are more basic for the survivorship of these older adults, being like eating, but also like hygiene, like in this case, bathing them. And then the other activities that are more related to mobility issues inside the household and getting out of bed are actually increasing the unmet needs for these older adults. So when we look at these demographic factors that are associated with met versus unmet needs, we see clearly that the demographic variables are important, and age actually is a very important contributor. Like as individuals get older, they're demanding more. They're receiving this maybe because they're also like in a more severe condition. So the questions we can't really disentangle so much with this data that we have explored so far. So we do have limitations, as Jackie mentioned. A lot of like our data is self-reported. We are really looking at the absolute nature of the unmet needs, right? We are not talking, for example, about the quality, if it's adequate and effective. These might be intertwined with like how individuals answer their questions about like being met versus not being met. Then when we look at the activities, we can think about a whole host of other activities that we haven't explored, like all the instrumental activities of the daily living. Older adults also needs like to be, provided with safety, and then there's like companionship and love. So many other things that might be unmet. But it's important to see that as the Mexican society gets older, we have like more and more challenges to actually be providing this care. And the take-home message is that, for the entire Latin America, I would say that like I also study a lot of Brazil, we can continue relying on families. Families are very strained to provide care. I think the COVID was a big example, as Jackie already pointed out, how older adults really had difficulties like navigating this year, doing their grocery, paying their bills, going to the doctors. So families got really strained in trying to provide this care, especially in the situation of a pandemic. And this varies across social groups. And that's why it is important that not one policy will fit everyone equally. And I'll stop here so we can actually have a little bit of discussion.
Wonderful. Thank you, Flavia.
Thank you, Flavia. Great job. I'm going to read you the first question over here is from Jackie Torres. Jackie, do you want to just read it? Go ahead.
Yeah, this is wonderful, and a wonderful paper, Flavia. And I was struck by how dramatic the trends were. I feel like it's so powerful to see the trends and unmet need over time. And it made me wonder, like, I've been struggling with these measures so much. And, I feel like they are so much about unmet need, even if that's not, they're also meant to capture severity. And so it kind of feels like the trends that you're showing make a little bit more of the case that this is an unmet need measure, and that's how I kind of intuitively interpret it. Anyway, I was just wondering what you thought about that. I guess the alternative interpretation is that there's a higher prevalence of ADL disability, but that the severity is lower. And so that's why they're reporting less help, which is how the HRS intended it. But I feel like anyway, I'm curious about your thoughts on that.
Yeah, and I agree. I feel that, the reporting is a big issue, right? So it might be that now individuals are more sensitive of saying, oh yes, I have a limitation on doing this. So when we look at the numbers, they really going up, even though we would need like to double check with like objective measures, that's for sure. And then when you also report about the unmet needs, right, it might be related to how adequate. Maybe you wanted to take shower and have someone helping you 5 days a week, and now you have, 3 days a week. And so the reporting might be that is inadequate because of that, or maybe the food was not warm as you wanted, or not exactly at the time you wanted, right? So we can't get in their minds with these questions, but I feel that it's important to see, and I think even with qualitative studies in Mexico, they do show that individuals are having this perception that they are going with more unmet needs, right? And the families that are providing a lot of this care, they also have fewer resources, right? Fewer people to do it, less time, and sometimes even like fewer financial resource. So thank you so much. And I know that Rebecca has a question.
Yeah, I'm going to leave it there for you. It's just that there's an additional question in the MHAS questionnaire that asks about your perception on the help that you're receiving. Is it enough, more than enough, or less than enough? And I was wondering, you guys looked at that question. Not yet,
Rebecca. Okay. So it's great that you pointed out, because I think that should be the next step to see the adequacy of it. So we look at the bare minimum at this point.
Sure. Yes, thank you. And as we know, this whole section of the questionnaires for both HRS types of studies and the MHAS, these are very time intensive. This whole help received is very, very taxing on the researchers. Thank you very much. I think we can move on to the next talk.
Super, and nice work, Flavia. We're going to move on to a presentation by Dr. Rogelio Saenz from the Department of Demography at the University of Texas at San Antonio, our sister school to UT Austin. Rogelio also is a policy fellow at the Carsey School of Public Policy at the University of New Hampshire, and as well as a longstanding member of the Conference Series on Aging the Americas Board. He has written extensively in the areas of demography, Latinos, Latinx, race and ethnic relations, inequality, immigration, public policy, social justice, and human rights. He is co-author of many books addressing these important issues, including co-editing the International Handbook of the Demography of Race and Ethnicity, as well as Latinos in the United States, Changing the Face of America. Rogelio is regularly writing for the press, takes a lot of interviews from national outlets, news outlets, and is currently on the circuit to address all these very important questions about Latinos and COVID-19. And so welcome, Rogelio, and let's see if you can share your slides.
Okay, let's see if I can succeed first. Yep.
Excellent.
Okay, and I'd like to begin by thanking Jackie and Rebecca for the invitation and for organizing this panel. So the title of my talk is Disproportionate Impact of COVID-19 on the Older Latino Mortality, the Rapidly Diminishing Latino Paradox and Implications for Elder Care. I'll provide a little bit of an introduction here, then the background that started my interest in this particular work, co-author piece that I had with Mark Garcia, that is very much tied to this presentation, kind of a theoretical grounding that we find with respect to the disproportionate impact of COVID on people of color, particularly Latinos, particularly Native Americans. Increasingly, that's becoming much more apparent as more data are available, as well as African Americans. And then I'll present the original findings from our study, and then I'll provide some updated findings, which are really interesting and provide kind of an added kind of context for understanding the diminishing paradox, and then I'll conclude with implications for Latino elder care. So the Latino paradox has been a mainstay in demography and public health and epidemiology, spanning back to the early work of our good friend and colleague Cocos Marquez, his very influential article in 1986 that identified the paradox. And immigrants play a very important role in the persistence of the paradox, because obviously it has been shown that by the time you're talking about second and particularly third and higher generations, you begin to see that the paradox disappears for those particular groups. And one of the interesting things in terms of thinking about the paradox, and particularly in terms of tying it to what was going on with the major decline of immigration from Mexico to the United States, that we see that there has been a tremendous decline of immigration from Mexico to the United States from 2008 to the present. So I had this thought in my mind in terms of making sure that keeping tabs of what is going on with the paradox to see if we eventually see that change. But for the most part, even though we're talking about the latest data would be 2018 or so, we're talking about a decade, and for the most part, we see that the paradox continue to persist. Perhaps at a later point in time, as you see the kind of the lags associated with the movement and so forth, and showing up with health and mortality kinds of patterns. But the pandemic had other plans for the Latino paradox. And a little bit of the background here. From the onset of the pandemic, it became very, very clear that people of color, and at that particular point in time, it was really journalists that were providing the images, the kind of data on the ground about what was going on. And we were seeing the devastation that was taking place on the African-American community and the Latino community. But there was much more information that was coming out on disproportionate kind of prevalence of cases and deaths in the African-American community. So we're seeing what was going on in New York, what was going on in Chicago, what was going on in Milwaukee and a variety of other places. But there was very little information on the Latino population. So I was fortunate enough to find a very obscure link by Black Lives Matter that had the sites where you had the state portals where you could go and find the data for those states that were providing data based upon race and Hispanic origin. And at that particular point in time, I think early on, we're talking about the second week of April, there were about 9 states that were providing information on Latinos, and as well as the San Francisco, New York City, and Washington, D.C. So it was from there that I started compiling the data, and it became easier because by early May or so, you begin seeing the COVID race tracker, for example, web page was putting weekly data together, then the CDC provisional data, and so forth. And at that point in time, we're talking about late April, early May, I started putting a series of monthly blogs with Latino decisions that called attention to what was going on in terms of the impact of COVID on the Latino community. And one of the earliest important findings tended to be, one, the overrepresentation of Latinos among people who were contracting the virus. So at that point in time, I think that there were about 35 states that had information on the infections and so forth. And Latinos were overrepresented in about 29 out of the 35. But on the other hand, if you looked at their proportional over or under representation with respect to mortality, it showed early on that in May that there was only one state, and that was New York, without the city, New York City, that was showing that their Latinos were overrepresented. So kind of a little bit of a puzzle, but it was really demography 101 that had to do with the very distinct age structures of the white population and the Latino population. So the median age, for example, of Latinos, 29.8 versus 44 for the white population. Whites have about 19% of, or about 20%, close to 21%, 65 and older, compared to about 7% for the Latino population, and so forth. Latinos are overrepresented, almost a third are children, and so forth. So early on, there was data from New York City, from the state of California, as well as the states of Utah that had data broken down by mortality and age. And once you computed age adjusted death rates, it was clearly showing that Latinos and African Americans were dying at rates about 3.5 times higher than the white population. And at that point in time, I was also keeping track of what was going on with the older age groups, and particularly with the overall paradox. And it was becoming very clear that there was the challenges to the paradox, that you were beginning to see a major decrease in terms of the gaps, the advantage that Latinos had. And at that point in time, I had been talking with Mark Garcia about the research that he was doing, as well as the research that I was doing. And then we collaborated on a piece. And then this is the article that appeared in Journal of Gerontology in the Social Sciences back in, I think it was in August, September or so, that we had gotten it published, that really shows what was going on. So before I go to the findings, kind of the theoretical grounding that comes from trying to understand the impact of COVID on people of color is very much in line with the systemic racism is the major culprit here. That many whites have been in denial regarding systemic racism as well as white supremacy, particularly in the general public. But then the pandemic, along with the murder of George Floyd and other people of color, including Latinos, makes it difficult to deny. And you see this confluence of inequalities that we find with respect to significantly higher infection and death rates of COVID among people of color compared to whites, essential workers on the front lines in essential industries being people of color, predominantly Latinos and African Americans, the loss of jobs and lack of job recovery that we've seen, the lack of medical insurance. In Texas, for example, something like 37% of Latinos 19 to 64 lack healthcare insurance. In the Valley area, where I'm originally from, in the border area, there are about 47% of Latinos 19 to 64 do not have healthcare insurance, as is the case for 3 out of every 4 individuals who are not U.S. citizens, and also about 1/6 of persons 65 and older that are not U.S. citizens lack healthcare insurance. The crowded living conditions in multi-generational households, as well as the unauthorized immigrants that were really have been left to fend for themselves with respect to the stimulus funding and unemployment rates and so forth. And these inequalities did not crop up during the pandemic, but rather reflect centuries and generations of neglect of people of color. And I always have been fond of the work of Sabrina Strings, who is a sociologist at University of California at Irvine. And she wrote a wonderful piece in the New York Times back in August or so that called attention to the concept of bare necessities for Blacks and other people of color, extending back to slavery and the racial subjugation of other groups of color, that there has been the minimal kind of investment in the well-being of people of color. The data sources, and as well as data limitations for the mortality analysis, I've been using CDC health disparities, race and Hispanic origin data. These are provisional death counts. Every week they update the new data, and it's broken down by states as well as race and ethnicity. The data limitations are that the data counts are provisional. They're constantly changing. There's lack of gender background, so we cannot see the distinctions in patterns between men and women. There is, for states, there is a suppression of COVID-19 deaths across states in age groups that have between 1 and 9 deaths. For the older population, it's not too much of a problem except in those states, for example, where Latinos and African Americans represent a very small share of the population, North Dakota, Wyoming, New Hampshire, and those kind of places. And then states vary tremendously in the processing of cases and deaths. And it's difficult to kind of, as you have one week to another, it's difficult to make temporal kind of comparisons because of those lag periods. And these are the results that come from the data that Mark and I published in the Journal of Gerontology. So we have 3 panels of data here, and these are data that were from February 1st to August 22nd, 2020. And then you see at the top there in panel A, it's the COVID-19 death rates, and these are the age-specific death rates, and for 55 to 64 all the way to 85 and older. And then in the middle you have, well, here what you really see is the major variations where Latinos and African Americans were being hit extremely hard. And we can see, for example, at the age group 55 to 64, Latinos and Blacks were dying at rates about 6 times higher than the white population. And even in the 85 and older, almost 2 times as higher probability of dying compared to whites. And then, so that's very much out of line with the paradox. And then in panel B is the residual deaths that are not COVID. And here you can see it's the Latino paradox world here. Latinos are dying across the board at rates that are about 23% lower than the white population. And then we go to the interesting one is the all causes here, because this is really where we see the impact of COVID on the paradox. And we see at this particular point in time, it was already the 65 to 74 age group, groups that were in the previous year in 2018, when there was the latest data, Latinos at this age group were dying at rates about 22% lower than the white population. And now it was about a 3% higher death rates. And you could see other groups, the 55 to 64, 0.99 almost, equal, as well as the 75 to 84 at 0.96, and the 85 and older at 0.84. And then we take data for each of the age groups, and we take the gaps between Latinos and whites extending back to 1999. And you can see very consistent across the board for each of these groups, showing that by 2018 or so, we're talking about 78%, ratio of about 0.78%. Again, whites dying at about 22% higher rates than the Latino population. And then you see the spikes go up in each of the age groups associated with the pandemic era. And now these are the updated. So now I've taken, just yesterday was the release of the latest week of data. And this now, before back in 2020, it used to be from February 1st to whatever the time period was. With the 2021 data, now we're going all the way back to January 1st, 2020. So these are cumulative data. And we can see for the most part that if you look at all ages, and these are all causes of death, we can see that here, Latinos are dying at a rate that is only about 4% lower than the white population. And now at the time that Mark and I wrote the article, it was the population 65 to 74, where we had seen the disappearance of the paradox there. And now what we find is the 55 to 64 age category is now Latinos have a higher death rate. And then interestingly, at the younger age categories, the 15 to 24 age category, as well as the 0 to 4, that we find that Latinos are dying at higher rates. So it's interesting that at first we're seeing kind of the focus on the older ages, but we see the other side of the spectrum that we see here. And particularly, I want to call attention to the 55 to 64 age category, because I think that this is really where you're seeing kind of the impact of the frontline workers. We're also seeing it at 65 to 74 and so forth, because people are still working at those ages, and they're more likely to be on the front lines, Latinos speaking. And it's very interesting, and I illustrate here the different impact that COVID has had on Latinos and whites, in that with the demography of whites who have died from COVID, about 89% are individuals 65 that were 65 years of age or older. With case of Latinos, it's 63%. So we find, for example, with the age group 55 to 64, 26%, they account for 26% of all Latinos who have died, compared to 9.6% in the white population. And then even in the 30 to 49 category, Latinos account for 9.4% of all Latino deaths, compared to 1.6% of whites who have died from COVID. And then to conclude here and call the implications for Latino elder care, it is a Latino paradox overall seems to be on the verge of disappearing in the midst of the pandemic, as we're talking about the latest data showing only a 4% advantage in all causes, all ages, death. And we already see that at the time that Mark and I wrote the article back in September. So it was only the 65 to 74 age category where we had seen Latinos now dying at rates overall higher than whites. And now we see the addition of the 55 to 64 age category, as well as on the other side of the spectrum, the 0 to 4 and the 15 to 24 age categories. And it is likely that other age groups are likely to follow suit in the near future. And these have major implications for Latino elder care. We continue to see the persistent inequalities, the lack of access to healthcare, the social networks, which for generations and centuries have been essential for the survival of Latinos in this country, that we continue to see the dangerous aspects of those social networks as well, particularly where you have the combination of ingredients that spread the virus, such as the pre-existing conditions, diabetes, obesity, and so forth, the multi-generational households. And we saw that particularly in the Los Angeles area, where we saw spikes that were taking place in December and January, and scholars calling attention to LA being one of the largest cities where we see among the highest percentages of multi-generational households and so forth. We see the great vulnerability of undocumented individuals that for the most part have been left to fend for themselves. And thankfully, we've seen community organizations. California has done a great job in terms of trying to vaccinate farm workers and so forth. And then we continue to see the current disparities in terms of vaccinations that we continue to see among Latinos and Latinas, people even in the older age categories that still are unable to secure vaccinations. I have an acquaintance here that used to work for us at UTSA, that she and her husband are in their late 60s and had been unable to get an appointment here, and they had to drive all the way from here, from San Antonio, all the way to the Corpus Christi area to get their first vaccination. And one of the questions is, will the Latino paradox return? And this is a question that often journalists ask, if it'll ever come back. And I think that my response has been that there's much unknown. Particularly, I think that we don't know for people who contracted the virus and have survived, we don't know what the long-term health consequences are going to be. I think there's going to be kind of lingering kind of health effects that are going to complicate the paradox. But there are a lot of the shortcomings, I think, having to do with the data that we have. Kind of the analysis that we're doing is kind of the big picture kind of a description of what is going on. But there are so many questions, so many very, very interesting and very fundamental questions that we cannot address. And I don't know the extent to which we will be able to go back and collect information on people who have died, the extent to which it has really impacted native-born or foreign-born Latinos, or more or not by social class and so forth. These are very, very interesting questions, and call really in terms of the data needs that we have for kind of beginning as scholars and researchers to begin looking long-term and to see what are the data that we're going to need to put together to address many of these long-term questions that are going to be that are of extreme importance and are going to be valuable in terms of trying to disentangle the regiments of inequality and racial inequality that exist, as well as how we go about back to regain our lives whenever we come out of the pandemic and prepare for and prepare for the next pandemic as well. And that's all I have. Yeah, and so muchas gracias, and there's the citation as well for the article. Okay.
Thank you very much, Rogelio, for a very thorough and inspirational talk, because then we have the marching orders. We have a lot of work to do moving forward, right?
Yeah.
Thank you very much. I have a couple of questions for you. One from Karen Fingerman. Karen, would you like to voice it? Bush.
Yes, sorry, it took me a second to unmute. I wanted to know, extending this to the vaccine efforts, which we have been reading about the disparities there. And so I just wanted you to comment on what you knew and what you think and so forth.
Yeah, it continues to show, I think, very clearly the disparities that exist here in San Antonio. I think the last figures that I was seeing suggested that something along the lines of approximately 10% or so of individuals who had received the vaccination were Latino. The same were even lower with the case of the African American population. In certain respects, you also find the role that the priority system has played with respect to age 65 and older. And we know that as I pointed out, 7.7% of Latinos are 65 and older. So you're already at a disadvantage there, unless you're an essential worker, for example, and that may go to the front of the line and so forth. So that, I think, continues to play a role in those disparities. I think that there is the issues having to do particularly for populations that have mobility problems, for example, as well as limitations in transportation and so forth. It's still very difficult for many to go to the specific locations. The digital divide, of course, that also here in San Antonio at the Alamo Dome, there was the date at which it was open, and in 5 minutes, all of the slots had been taken. This was about a month ago or so. So for people with limited resources, people of color and so forth, and you can think of the older individuals as well that don't have the access to technology. This makes it extremely, extremely difficult. Here in San Antonio, we're also seeing kind of the firefighters that were also involved in trying to go to particular locations around the community to try to make those vaccinations available. And then I think that there's continues to be, unfortunately, the misinformation that is also existing within the community, and it really goes back to the disparities that we've seen along racial lines historically, with people of color, African Americans, for example, being guinea pigs for experiments and so forth, and the distrust that exists and so forth. And we find that as well in the Latino community as well. And then, of course, you also have the added kind of complication, are individuals who are undocumented, and the fear of that they're going to be asking for their status, citizenship status, and so forth, and their risk of being deported, as well as the other factor.
Yep.
Yeah.
Thank you, Rogelio. I have a comment from Deborah Amberson: major implications for bereavement and loss in Latinx communities as well. Looking forward. then Jackie Angel has another comment, but I think we're running out of time. She's asking about local municipalities in Texas, whether they're addressing the health inequalities in the underserved Latino population. Are there any special efforts in San Antonio, for example?
Yeah, these are excellent questions. And I think that the bereavement is something that is, in many respects, it's the kind of, it will be the postponement of bereavement.
Yes.
And the extent to which, particularly in New York, for example, back in April and May, in the Valley area, in July and August, that there was, bodies piling up and so forth, and El Paso most recently. And there's a lot of the shell shock at that particular point in time. I think that this is going to be a long-term process. The extent to which we're going to have holes in our families, holes in our communities, and so forth that are never going to go away, and that we're going to continue being in bereavement and so forth. I think that communities have tried to help out, particularly, and people often say, okay, if you were able to pick what is the priority area, it's very difficult because you look at housing, you look at education, you look at jobs, they're all health, and they're so interconnected. And I think that communities with resources here in San Antonio, there has been efforts to try to provide assistance to people, but at the same time, we see the homeless, for example, being uprooted for homeless areas and so forth. And we seem in certain respects, and this is not here only in San Antonio, but throughout the country, that we seem to be realize the disparities that exist. But then as we make decisions and so forth, we see those disparities continue to reproduce themselves. And I think that Americans, like people all over the world, we have very short-term memories, and people have an idea that there is systemic racism that is real, that there's this value of essential workers that have been putting food on our table, keeping us fed and safe, and so forth. But I always say, what happens the day after the pandemic, whether we go back to the business as usual, and we know that racism is a system that continues to adjust and reproduce itself, and that is going to be the forces that we're going to have to fight against.
Yeah. Thank you, Rogelio. I think, Jackie, do you want to close the panel?
Thank you, Rebecca. This has been such a very informative and excellent session. I'm so glad all of you had the opportunity to join us this morning. We will have more of these sessions, including our upcoming 2021 ICA in Galveston.